Welcome to the lecture for Crisis Intervention. We're talking about Chapter 7 of Aguilera today, which deals with issues related to crises, related to infertility. So to start off just by defining some things, what is infertility? Well, it's either the inability to get pregnant after having regular sexual relations for 1 year, so 1 year of trying to have a baby and not being successful, or the inability to carry a pregnancy to live birth, which includes instances of both miscarriage and stillbirth. And the difference between miscarriage and stillbirth is a matter of timing. Miscarriage is a loss of a pregnancy prior to 20 weeks gestation. So in the first 20 weeks, if you lose the baby, it's a miscarriage, also called spontaneous abortion. And if the pregnancy is lost after the 20th week, before birth, it's called a stillbirth. So some things to think about: the prevalence of infertility. 15 to 25% of couples who are trying to get pregnant experience one or more of the forms of infertility we just talked about. And similarly, kind of the rates of miscarriage, about 25% of couples experience a miscarriage, not being able to get pregnant, but having a miscarriage at some point in time. Um, the majority of miscarriages, however, occur before the woman even realizes she's pregnant. So when we say, oh, about 25% of miscarriage, actually probably way more common than that, but people aren't aware of it, so it's not going to be a crisis in those cases. But studies done with extremely sensitive pregnancy tests show that almost half of all pregnancies where you have fertilized egg miscarry before the fertilized egg implants itself in the uterus. After a pregnancy is clinically recognized, which is about 35 to 50 days into the pregnancy, the risk is down to about 25%. So 25% of pregnancies will miscarry at that point. And then when the woman gets to 8 weeks pregnant, the risk is down to just about 10%. And then once an ultrasound has been performed to confirm the fetus is viable, the risk shrinks down to just 3%. And then stillbirth, which is after 20 weeks, occurs in less than 1% of pregnancies. So the risk of miscarriage decreases as gestation progresses. So the longer that zygote is able to develop into an embryo and fetus and all that, the more likely it's going to result in a live birth. Some people experience recurrent miscarriages, and this isn't just more than one miscarriage. It's kind of a clinical term for 3 consecutive miscarriages, which happens to about 1% of women. And we'll talk in a minute about causes in general of infertility and miscarriages. Just a note on recurrent miscarriages. It's not clearly understood why it happens. In several couples, you can have recurrent miscarriages with 3 different reasons. So it's not necessarily like there's something wrong that's causing the recurrent miscarriages. There could be all the things that cause miscarriages going on at these different times, or again, there could be one reason that's causing the inability to carry a child to full time. But in terms of causes, Aguilera talks about emotional causes. Says that 5% of the problems are caused by emotional factors. I'm not sure where that number came from. Aguilera doesn't provide a citation, and in my reading, I haven't seen anything that mentions that as a number, or really talks much about emotional factors. We do know that about 30% of the time when infertility is an issue, it's due to unexplained causes. And often when it's unexplained, we suspect anxiety or stress may play a role. And anxiety and stress do affect the body, in terms of hormones and everything. But they also influence behaviors that affect the body, consumption of alcohol and caffeine, the quantity and quality of sleep. So these are things to think about. But just because you suspect it may be emotional, you don't know. And really, unknown cause is unknown cause. The most frequent culprit to infertility appears to be a combination of genetic factors, and it can be a lot of different things going on that all fall in the category of genetic factors. It could be mother's genetics, father's genetics, or it could be a match of the two. But one kind of newer finding that's come out is paternal age. So fathers over 40, there's a greater risk of miscarriage with that. And again, that's thought to be kind of via these genetic influences. Maybe it's the DNA in the sperm aren't the same as they were earlier in the man's life in the sperm that he produced earlier. It's possible that there are more mutations in the genetic code as time goes on. And he's been exposed to more toxins in the environment. Like I said, neither the men nor women are more likely to be the cause. It's like, oh, it's more likely to be the man's fault or the woman's fault. Doesn't seem to be the case. And frequently it seems to be a matter of the couple and something about the match. But equally likely for if there is kind of one person who has is contributing more to the problem biologically, it's about equally occurs between men and women. There are some, we talk about modifiable factors, so there's some things that people can do to decrease the risk. There's some things that are just uncontrollable. Your genetics aren't really controllable. You're born with what you got until science advances, maybe the next couple of years. But there are some things you can do to decrease the likelihood of having fertility problems. Things like, we know things that contribute to infertility and contribute to miscarriage in particular would be smoking, extreme weight, either very large or very small, having a sexually transmitted infection, and then also caffeine use. And the smoking and caffeine both work to reduce either blood flow or oxygen that's available to support a growing fetus. And then, so those are all things that are modifiable related to infertility and miscarriage. And then stillbirth, which again is pretty rare. There's a couple of identified risk factors for that, some of which are teenaged and advanced maternal age, so really young mothers, and then older mothers, prolonged obstructed labor, so somebody's having difficulty giving birth and the baby can't get out, stillbirth can happen. High level of cesarean section refusal, so moms or couples who just don't want to have a cesarean and the infant is in distress or the fetus is in distress and they don't want to have the surgery, they might not make it to a live birth. Type 2 diabetes, malnutrition, infection, inadequate prenatal care, and then lack of emergency obstetric care. So if you're doing kind of home birthing and something goes wrong or is atypical, if there's not somebody there who's capable of delivering a difficult birth, handles emergency procedures, the risk of stillbirth goes up. So one thing I want you to be thinking about before we meet is, as we've talked about kind of all these reasons for infertility and some characteristics of it, why is it important that you, as a clinician, as a mental health care worker, are aware of the causes? So think about that. Okay, so infertility as a crisis. Well, when this presents, it's probably going to be either a current client of yours who is a client of yours for some other reason, and then they experience kind of the crisis-related infertility, or be a referral from a physician. Individuals and couples are unlikely to present for this problem unless referred by a healthcare worker. This is another thing I want you to be thinking about. We'll talk about in classes. Why is this? Why don't people, we know it causes kind of emotional turmoil. When people go through this difficult experience, why don't they typically present to mental health care workers to get some help getting through this time? So think about that. Think about what your answers might be. The experience of infertility can be similar to experience of grieving for a loss, right? And in loss in terms of if there's a miscarriage or stillbirth where there was a life that's not there anymore, didn't get born, that's a loss. And then people who, even if they don't necessarily have miscarriage, but they realize they're not able to get pregnant, there's a grieving for the loss of what they had envisioned. Usually you have this kind of Some people have an imagined child that, okay, one day I'm going to have kids and I'll do these things with them. They kind of have a picture in their mind's eye of what it would be like if they find out that they can't have biological children. Part of that vision dies, and you say, well, they can still have kids, adoption, and those are all great options. But that part of that vision of having your own biological child is gone, and there's kind of a grief reaction to that frequently. So in addition to that, as being kind of part of the crisis, there can be anxiety about the future. They don't know what's going to happen. Can we have kids? Are we not going to be able to have kids? We just don't know. In that anxiety, if the anxiety is unmanageable, can lead to a psychological crisis. Right? In Aguilera, she also talks about Minning's stages of infertility, which talks about the reaction to infertility for couples. This kind of stage model talks about surprise, denial, anger, isolation, guilt, grief, and finally resolution. Right? And the suggestion here is that these stages occur in a logical order. You kind of proceed through them. And many of you are probably familiar with the Kubler-Ross stage model of grieving. And similar claims were made about that model when it came out. That okay, people progress from denial to anger or whatever. But research doesn't really support a linear progression in these kind of models. At least for Kubler-Ross, and probably not for Minnings either. These people are so different, they don't typically go through one stage clearly, and then the next, and then the next. And not everybody experiences all the stages. So it's not necessarily linear. They may not experience all of these things. And sometimes there's not clear demarcations between them. Like denial and anger. It may not be you're in denial and then that's done and now you're angry. It could be combined where no, this isn't happening and you're kind of really pissed off about it even though you're saying it's not happening. So they're not clearly distinct stages. They may be kind of overlapping experiences. So I don't want you to think about this model, or probably most stage models, as kind of clearly distinct stages. Nonetheless, I think the model is helpful for getting us to think about some of the common reactions that may be experienced in people in this group facing this problem. And again, they may not have all of these pieces of the reaction, but these are common reactions, and so they'll probably experience many of them. So it's important to kind of be aware of that, and we can probably map this onto Aguilera's model and thinking about where they fit in terms of how it influences the perception and also the coping behaviors they might be using. Right? Because thinking about denial obviously being one way of coping. But another thing that's kind of mentioned in this model that I like was this idea of reactivation. I think it brought up a good point that even if the feelings regarding infertility, so the surprise, the anger, the guilt, the grief, if they're resolved in some way, so you move forward. Reactivation is the idea that those feelings all may come back, right? Either on the anniversary events, like maybe a year after you lost the pregnancy, or going to somebody else's baby shower, reading about infertility for this class, maybe a reactivating event for some people. So they do recognize that even when you're kind of done, you may not be done, and you can kind of experience all these things all over again, which is important to know about, and it's important also to educate clients about for this problem and other problems as well, that very rarely are we really fully over things. Right? We deal with them best we can, and we maybe return to a level of functioning, but then we want to plan for, okay, if this becomes a problem again, what am I going to do, and how might I be different and handle it differently the next time? Another thing to think about in terms of working with the issue of infertility, I think it's important to work with both members of the couple if possible and relevant for a variety of reasons. It may not be relevant. It could be you have a mother or a father who isn't with another person but is trying to have a child through a surrogate or some other process, and there's not another really parent involved, but your client is having problems conceiving or carrying a child to term. But generally, we think about this being two people who are both trying to have a baby. And when that's the case, it's good to treat them as a couple, not necessarily, okay, let's have both of them in individual counseling. That may be all well and good, but it's also really important to treat them as a couple and do kind of couples work with them. For a couple of reasons. Like I said, one is it really is a couples issue, right? It affects both members of the couple, but it also affects their relationship. Right? And if it affects their relationship, then it's not, one person's issue and the other person's issue. It's both of their issues together. Another thing is working with the couple together helps get at sorting through any kind of excuse me blame that's going on, because there frequently is a tendency to blame when things go wrong. Not necessarily blaming the person, maybe self-blame. Oh, I feel like it's all my fault. And if somebody feels like it's all their fault and they isolate themselves from the other person and they draw back, and the other person might think, oh, they're pulling away, they must blame me, because again, they're trying to figure out who's to blame. And if you're doing couples work, you can sort through that, clarify any misunderstandings, miscommunications, and help them come up with a better understanding of blame and responsibility, and a healthier understanding. And lastly, for this issue, frequently individuals have differences in coping, and if it's a heterosexual couple, and you've got a man and woman, and men and women have there's some pretty common sex differences in coping styles between men and women. And when you have differences in coping or grieving, this can cause misunderstandings too. If one person copes by withdrawing and the other person copes by reaching out, you've got a mismatch there, and you're gonna create this kind of approach avoidance cycle that can really be troublesome. But seeing them as a couple, you can kind of bridge these gaps and educate them about, okay, this is how you normally cope, this is how you normally cope. You both have to find a new way of doing this together. And there is an emphasis on, it's your issue together, and to figure out a way to deal with it together, not just you each doing your own thing. Okay. Finally, we can think about applying Aguilera's model specifically to this group of problems. And I want us to talk in class about how to apply the model. So I'll just point out a few specific things I want you to think about for now related to the model. In terms of the perception of the event, one cognition that Aguilera mentions for this type of crisis was the mystical belief that the fertility problem was God's punishment. So my question for you to think about, how would you deal with this cognition without imposing your own religious or spiritual values? Okay. So that idea of, okay, we can't have a baby or I lost a baby because God's punishing us, punishing me, punishing him, punishing her. How do you deal with that without saying, okay, well, in the Bible I read it says, or in the Quran I read it says? How do you deal with that kind of religious thought without imposing your own religious values? In terms of situational supports, it's important for you as a therapist to be knowledgeable about fertility issues. That's why we're talking about it. If you're going to work with these couples, but you're not expected to take the place of a physician, right? Because you're ethically obligated to practice within your area of competence, and none of us are competent to practice as physicians. So it's important to refer and make connections with other professionals, and for this issue, other professionals that have some expertise in fertility issues. Because again, just because somebody's a doctor doesn't mean they're a fertility expert. That is a subspecialty of medicine. And finally, for coping behaviors, when you're thinking about coping behaviors to discuss in class, because we'll go through the model in class with this issue, when you're trying to think about what coping behaviors you would recommend, think about two things. One, think about things an individual could do, a mother or a father, and how those might be different. And then think about things that a couple could do and maybe should do together. So kind of these joint coping behaviors. Okay, so wrapping up the things I want you to remember to think about. Why is it important that you, as a clinician, are aware of the causes of infertility? Why are couples unlikely to present for therapy when struggling with infertility? And then how do you apply the model to this issue. And within that, think about the punishment from God thing, and then the two different types of coping skills. Okay? Take care.